Now, it's almost a cliche that the COVID-19 pandemic has turned the world upside down. As of October 22nd, 2021, 242 million cases and 4.93 million deaths were confirmed worldwide. The two waves spared no country, no section of society, no healthcare system, and no economy. Death, serious illness, hospitalization plagued the richest to the poorest. The US reported 4,53 crore cases, deaths 7.33 lakhs. Till September 2021, India reported the second highest number of cases after USA, 3 crores 36 lakhs 78,786 cases, and third number of deaths, 4,52,811 after US and Brazil. What did the pandemic mean for middle-income countries like India? We saw hordes of migrant workers fleeing on foot to their villages following the lockdown. Caretakers of COVID patients desperately seeking oxygen cylinders and hospital beds, and mass cremation sites. The pandemic exposed the fault lines in every sphere of life: healthcare, social, political, and economic. With no sign of the third wave, which was supposed to peak in mid-October, we seem to be in a good place to take stock. What are the lessons we can learn from the past 2 years? Can we afford to be complacent? We have a distinguished panel to share their thoughts with us. Dr. Gagandeep Kang is professor in the Department of Gastrointestinal Sciences at the Christian Medical College, Vellore. She is a member of the National Task Force Against COVID set up in May 2021. Dr. K. Srinath Reddy is President, Public Health Foundation of India, and formerly headed the Department of Cardiology at the All India Institute of Medical Sciences. Veteran economist Prof Arun Kumar is Malcolm Adiseshiah Chair, Professor at Institute of Social Sciences, New Delhi, and former Professor, Center for Economic Studies and Planning, JNU, Delhi. He has authored 5 critically acclaimed books. All the 3 of them have been written about and spoken extensively in the media through the pandemic. They have also been invited to various government meetings. Dr. Kang is the co-author with Dr. Chandrakant Laheria and Randeep Guleria of bestseller Till We Win, India's Fight Against the COVID-19 Pandemic. Professor Arun Kumar's most recent book is Indian Economy's Greatest Crisis, Impact of Coronavirus and the Road Ahead. Our moderator for this session is Kamini Mahadevan, who was with the Penguin Group, including Pearson Education India, for almost 2 decades. She retired from the Penguin Books India as consultant editor. At Penguin, she had the privilege of publishing several eminent and award-winning authors and translators. She lives in Bangalore and freelances. And now, Dr. Kang, Dr. Reddy, Professor Kumar, Ms. Mahadevan, over to you.
So, I think it's almost a cliche that the 19 pandemic has turned the world upside down. And the 2 waves have spared no country, no section of society, no healthcare system, and no economy. And even the richest of countries, the US, leads the leads the numbers as far as deaths are concerned. And India is in fact third online. So we are, with the death rate hitting 0 in Delhi this week, and we are being in a slightly more quiescent phase, as Dr. Reddy says, I think we are in a good place to take stock of how things are. So we are privileged to have Dr. Gagandeep Kang, Dr. Reddy, and Dr. Arun Kumar. And Dr. Arun Kumar, Professor Arun Kumar, has written a book, in fact, on Indian economy's greatest crisis, the fight against COVID. And of course, Professor Kang, you've been co-author with Chandrakant Laheria and Randeep Guleria on Till We Win. So, and both these publications came out around the same time in the end of 2020. So may I request you, Dr. Kang, to set the ball rolling? Could we wind back to January 2020? By then, it was evident from reports from Wuhan, Italy, and the US that the virus was spreading fast. And between end of January and end of March, when WHO declared the pandemic and India announced a total lockdown overnight, could we anticipate how things would develop? I mean, in terms of how viruses behave in general and the COVID virus in particular. I mean, did we know enough about the virus at that point of time?
So during that time, I was at a number of meetings in the UK and elsewhere where we did discuss the virus and thought that it was an under-recognized threat. Anytime there is a respiratory virus, the infectious disease community sort of goes into this phase of near panic because nobody else understands just how easily a respiratory virus can spread. You know, the Ebolas of this world are dangerous viruses. They are highly fatal viruses, but they don't spread as easily as a respiratory virus does. Now, previously, when the community has worried about a respiratory virus, it was done. And in a sense, we were wrong there because it was a pandemic, but the virus, fortunately for us, was a relatively mild virus, capable of transmission, but there were people who had had exposure to H1N1 before, and it resulted in deaths, but not at a level that we thought we would see. In the as we knew, which was in late January, that this could spread from asymptomatic infections, everybody's danger signals were firing up at that time. And it was hard to make countries and governments understand that this was a very real threat. I came back to India and we had discussions in India about why nothing was happening, why to one laboratory for the first 6 weeks after tests became available. It was like nobody was understanding how much this was going to blow up in our faces. Even then, even with all of that, I think as an infectious disease community, we underestimated how quickly it could spread and the damage that it could do because we hadn't seen anything like it before.
Right, right. So in some senses, we had that window February, March. Was there any other option for us to go on lockdown mode overnight? I mean, I'd like all three of you to sort of respond to that.
So India is a very different country from other countries. And the timing of the lockdown and the preparation to use lockdowns well is something that needs to be considered. I think in terms of when we locked down, we probably locked down at the right time or too early. Definitely not too late. Okay. But what we did not do is prepare for how we would use the time of the lockdown. If the goal was to make sure that we had systems in place to be able to find and isolate every case of the virus, we were still at the stage of lockdown only testing people who were traveling overseas or their contacts. And that was insufficient because we were seeing cases that had no history of travel and no history of contact.
Yeah. Dr. Reddy, what were your thoughts on this matter? I mean, if we had, because I do remember even in February, there were messages going around, if not masking, at least social distancing and hand hygiene and all. So, I mean, can you, dwell on whether we needed to lock down immediately?
No, I don't think we needed to lock down immediately. I agree with Dr. Gagandeep Kang that possibly we locked down a little too early and too extensively. All of India did not need to go into lockdown. the virus entered into the metros through international airports and international entry points.
Right.
Of course, then it started spreading to the surrounding districts as well, but mostly it was an urban phenomenon at that time.
Right.
And we should have actually tried to contain it within those urban territories in terms of the spread. It might have eventually spread further, but then we could have contained a good deal of damage initially.
Yeah.
The other element, of course, is, you rightly pointed out that masks were being advised, but there was a lot of ambivalence about the masks, partly because of the WHO's position. Even the Indian government took the position that it's only people who are suffering who must wear the masks, not others. And in fact, it was said that spare the masks for the hospitals, don't wear it and waste it. So, and the WHO till April end of 2021 did not recognize aerosol transmission. I mean, much later. While we have had experiential wisdom from Southeast Asian and East Asian countries during SARS-1, etc., that masks were required and that there is likelihood of an aerosol transmission. Much has been discussed about how this mistake also about aerosol transmission came in, about the 5 micron size versus 100 micron size. All that controversy has been unveiled now. So in a sense, we could have taken several other measures. Yes, testing should have been much more extensive. Contact tracing could have been much more extensive. But then we also did not know that a lot of asymptomatic infections were also happening. And there's no way you could have tested them at that point in time, or even contact trace people. So there would have been spread of a respiratory virus, which was going through aerosols, which was going through droplets, which was also creating asymptomatically infected people. Nevertheless, a lot of precautions could have been taken to contain the transmission by avoiding super spreader events and advising people masks early on. Some of these things could have been done. Testing kits were in short supply everywhere. People were fighting all over the place. Even the United States was grabbing testing kits which were ordered by European countries right from the seaports. I mean, that was the state of affairs. But certainly, we could have ramped up a lot of things much faster, but kept the caution in terms of public health measures much stronger.
Yes, Arun, I mean...
Yeah. So, I had first flagged this issue in a semi-official meeting where there were not only economists, but also some administrators on 24th January, that this is going to blow up in our face, because the reports from China were quite disturbing already, and on February 18, there was another semi-official meeting in which I again mentioned, and some of the people who were there on January 24th agreed that things were getting quite hot and that we needed to do something. But we didn't do anything very much, we sort of were in a very relaxed mood, and we did not do what we needed to do in terms of lockdown. Now, what is important to realize is that in India, 94% of the workforce is in the unorganized sector, and they're not able to take care of the issues that come up. Their living conditions are very unhygienic, etc. So, a lockdown was essential, but the imperatives of lockdown were even more essential. A lockdown would not succeed unless you made special provisions for the unorganized sector, those living in the slums. In Dharvi, there may be 10 people to a room and they sleep in shifts. Now, how do they isolate themselves 24/7 unless you disperse them? They also, 90% said in a survey that they didn't have enough money to buy 1 week's supplies. So you needed to provide them with essentials where they were. So not only did we need to disperse them, but also provide supplies. And as Dr. Reddy is saying, we didn't have enough testing. We didn't do enough contact tracing, which we could have started very quickly. There were already reports that WHO was delaying the declaration of pandemic. It declared only on March 10th or 11th. I forget which is the exact date.
31st, in fact, yeah.
I think 10th or 11th March is when they declared that there was a pandemic going on. But they could have declared it much earlier, according to many experts. So, India, because of our very poor administration, very poor health systems, and you see, a lockdown is not a solution to the disease, but it prevents the numbers from exploding. Like for instance, New York saw a massive explosion. It almost crossed the medical capacity there. And we saw in the first wave and second wave, because the disease continued to spread, that we almost crossed our maximum limit, both in Delhi, Bombay, and in other parts, metros and so on. So I think in my judgment, and also if you compare China with what happened in China with what happened in the US or what happened in Brazil, China managed to control very quickly because of the lockdown. They delayed the declaration, but they managed to control, and their economy started reviving within 2.5 months of declaring the first lockdown. Whereas Brazil, it continued because they never declared a lockdown. In the USA, the lockdown was state-wise, and therefore the disease continued to spread. And you have the first wave merge into the second wave, into the third wave. In Brazil, it happened also in the US that the first wave merged into the second wave. So, a lockdown becomes essential because we neither had medicine nor did we have vaccine. How do you slow it down? And as Dr. Reddy said, people had already come in. January 30th was the first case in Kerala. So, the disease was spreading. So we needed a lockdown, but it had to be calibrated. It had to be done, as Dr. Reddy said, starting with the urban areas, and then maybe if it spread to rural areas, to also spread it there. But then you have to take care of the unorganized sector. Otherwise, it wasn't going to work. And therefore, we started unlocking in India in June, when the number of cases was still rising. And that's why the number of cases kept on rising till September middle. And then only they started going down.
It's interesting because, Arun, you've pointed out that in a war, in your book, you say, we were in a war, at least productive activity goes on. But in this case, because, you had migrant labor leaving the city and all production activity came to a halt. So if there had been better preparedness, do you think this sort of productive activity could have continued despite the lockdown?
No, if you have a lockdown, then it means people cannot go out. And you see, the unorganized sector works with very small amount of capital. So within a week or so, they'll exhaust their capital. If you think of a pavement seller, he just has enough capital to last a week or 2 weeks at the most. Now, if you have a lockdown for a month or 2 months, he's going to exhaust the capital. And that's why you have to provide him with the essentials wherever he is. If you don't do that, then there'd be starvation. And, as people said, they didn't have money even for 1 week's supplies. So they started migrating, because at least in rural areas, you get food. In the urban areas, you have to buy food, and which was going to be difficult. Plus, because of congestion, you cannot practice, isolation. So you had to be dispersed. So when I say it was like a warlike situation, what I meant was that, you see, the demand declined and employment collapsed. And when employment collapses, people's incomes collapse. And not only that, many people were still in employment, but they were not going to work. So GDP was collapsing. And therefore, the distinction between employment and work has to be made. The employment as per CMIE data declined by 122 million, but my estimate is that 200 million people did not work, which meant that the GDP declined by some like 75%, and that was a huge hit. And that was going to happen with lockdown. But the imperatives of lockdown had to be taken care of because we were in a warlike situation. Supplies were disrupted, demand had come down, which doesn't happen in a war situation. The demand doesn't come down. People are fighting, people are producing for the war. So unemployment is not there. But now, so lockdown is worse than a war in that sense.
Yeah. What would be the lessons, Dr. Kang and Dr. Reddy, in your opinion, of the first wave? Things which we could have carried over to the second wave?
I think the fact that preparedness and resilience within the system is critical. It's very easy to let your guard slip. I think one of the things that happened during the first wave that the government tried to redress, and in the period after the first wave, was the kinds of services that had suffered during the first wave, which is a lot of women delivering outside of hospitals, maternal mortality rates going up, immunization coming down. And then when we had the second wave, the way that was used to try and handle that was to try and make sure that medical services were not impacted. But that didn't really work because you went the same route of converting a lot of facilities to only COVID facilities, which meant that healthcare systems both public and private, that are geared to offer a certain set of services were no longer able to offer. The other thing that we didn't do very well during the first wave, that I wish we'd tried to do better during the second wave, was trying to understand what tests to use, where to use them, and what action to take when a test is positive. Every state did its own thing. Some states used PCRs only, some states used rapid antigen tests only. The who was being tested where varied by state. We pegged everything on this magic number called the test positivity rate. And that's a number that's relatively easy to gain. So when it came to the detection of cases, essentially states were able to figure out during the second wave from their experience in the first that you could project a picture that you wanted to project just by changing the strategy that you were using. The other thing that was really important from the first wave was the idea of preparedness for the kind of care that was going to be needed in hospitals. And we developed new ventilators. We didn't see whether those ventilators were functional or whether they were required. We had the government develop a protocol for treatment of patients that didn't change over 8 months, even as new evidence came out that showed us that some of the drugs that were untested and therefore potentially could have had a justification for use as in clinical trials had been shown not to work. And this persisted right into the second wave. So there were lots of lessons. We could have built a system where we could have evaluated new strategies. We didn't do anything about that. So I think lots of lessons, and I'd like to come back to that later if there's time.
Sure, no, absolutely. Dr. Reddy, please.
Well, one of the lessons that we should have learned is that within the health system, primary care is very, very important, especially in a pandemic response, apart from the steady state. Of course, you must have an efficient and equitable health system functioning well in the steady state in order to mount a swift and strong surge response when challenged with a public health emergency. And every country has realized that, and we too did. But one of the most neglected areas has been primary care. Urban primary care virtually hasn't existed. We trusted the big hospitals to take care of everybody in the cities. Whereas in primary care, early detection of cases based on household surveillance of symptoms, what we call syndromic surveillance, could have led to early detection of cases, early referral for testing, then triage to see whether home care could have been provided, assisted, supervised home care, supported home care, rather than rushing to hospital for everybody. Those are the elements where, and even countering fear, stigma, misconception, and for the second wave, building up vaccine confidence. All of these are primary care functions. And neglecting primary care, we went straight to tertiary care, and ventilator became the big symbol of our response in the first wave. We neglected the oxygen component of it. The secondary care too was important. District hospitals equipped with reliable oxygen supply, or even other hospitals, municipal hospitals with reliable oxygen supply, would have served a great purpose. And in the first wave, the virus was not as infectious as in the Delta variant. And therefore, we could have actually mounted a much better response if we had taken all these into account. And home care was not even talked about. It was only in the second wave that home care started getting attention. And we also lost citizen connect. Unless you engage citizenry, your contact tracing is not going to be very helpful. Your early reporting of cases is not going to happen. And we did not engage the community-based organizations and the citizen groups effectively in the first wave. So these are all the lessons that we should have carried into the second wave, which we did partially, I must say. But these are the things we must build on from now on to ensure that we don't have a health system that crumbles in the face of a public health emergency challenge.
Right. No, because what is interesting, of course, is that immunization had started in January, February 2020. 2021. Yeah, it had already started then. I mean, healthcare workers frontline workers were immunized, and in March, the elderly were already being immunized. And despite that, I mean, when it came into the second wave, it's just overwhelmed everybody, I think. So, do you think that people just didn't know about this Delta variant enough? Dr. Kang and Dr. Reddy, because, this time younger people also got affected. I mean, we had 30-year-olds dying.
So I think the patterns of infection that we started to see first in districts in Maharashtra and then in Delhi seemed to indicate that there was something going on that could not be explained by a virus that behaved like the ancestral variant had behaved. So this was something that was brought up in discussion with a number of people, and there was no explanation except that this was a variant, but none of the sequencing data that was available in the public domain was, we were constantly told that there's nothing special about it. So we spoke to people from INSACOG, we spoke to people from the government and asked them, what's going on? There has to be an explanation. Now, we understand in hindsight from reports in the media that some of this information from INSACOG had been conveyed to the government, and perhaps its import wasn't recognized or acknowledged or explained in the right way. But I think one of the problems that we continue to have with our sequencing data, even though sequencing has expanded hugely, is the fact that we are not linking different data sources together to get a fuller picture of what is going on. And this was a problem back in February. It's been a problem throughout every phase of the pandemic. Even today, the sequencing data does not link to the clinical information. All you have is when the sample was collected and what sequence it is.
Yeah.
That gives you some information, but it's not sufficient for us to be able to act on it as quickly as we need to. So I hope that that changes in the future.
Right. Yeah. Dr. Reddy, what do you feel about that?
Well, clearly variants are emerging, some of them more infectious than others, some of them possibly more virulent than others. But over a period of time, it is in the nature of the virus to try and develop more variants. Some of them will endure if there is evolutionary success for those variants to spread faster. And if it continues to do so, then it will remain that way. Whether it grows more virulent or less virulent depends also on our responses.
Yeah.
If we actually create a difficult path for it to transmit by wearing masks, avoiding super spreader events, and by vaccinating people, it may want to continue through a variant that is more infectious but less virulent because it will not want to exhaust its own host. But in terms of the Delta variant itself and our own experience, perhaps our recognition that we have a newcomer that is much more infectious, much more readily transmissible, much more infectious in family clusters. This clinical recognition, which came early in February in Mumbai, should have actually translated into public awareness and policymaker response earlier than it did. It took a while for that. And it's possible that we could have avoided some of the fatalities if we had actually made knowledge much more widespread. We depended a lot on the report of the genomic testing, which was still being ramped up at that stage.
Mm-hmm. Yeah, because it was uncanny how younger people were being affected, and which brings me to this whole question of, sort of blocking the passages for the transmission of the virus. Would you, Dr. Kang, would you like to talk about, the vaccination? I know at one stage, this whole question of blanket immunization was talked about and universal immunization was talked about. Would you like to sort of tell us something about the possibilities of what are the things about universal immunization? What are our sort of hurdles to universal immunization in India?
There are actually no hurdles to universal immunization. If you have vaccines that are widely available, licensed for use in every age group, there's nothing stopping us from immunizing everybody in the country. The question really is, which vaccine do you use for whom and when, right? So the priority has to be, for a new disease, it has to be risk groups. And risk groups are the elderly and people with comorbidities across all ages. Unfortunately, because we have opened up vaccination to everybody in a very short time frame, it has had some advantages and some disadvantages. The advantage is that you don't need to keep going back to the same community many times because you can immunize a wider age group when you go into a community. And that works well when you're accessing populations that are remote or underserved for some reason or the other. It has the disadvantage that it takes away from the focus of protecting the people who are most vulnerable first. What you would like to do, and what has been the approach that has been taken and has served other countries well and might not have been suitable for us, is to have a very age descending strategy where you vaccinate first the oldest age groups and people with comorbidities and then come down through the age groups. The big question in India today is, should we be vaccinating children?
Yeah.
And I worry about that again, because if the focus is literally on the number of doses that you're delivering, we've gotten to 1 billion, we'll get to 1.5 billion, right? But are you vaccinating the people who need it the most? It becomes very easy to lose those vulnerable people in the larger numbers. And that's why I've been reluctant to say that we should move into children immediately. I also think that there are scientific reasons why we should think carefully before we move into children. And those relate to the fact that children seem to be able to handle this virus very well if they are healthy. There is a very tiny proportion of children that develop a multi-inflammatory syndrome, but mostly children do well. Healthy children will do well. Children with comorbidities will continue to be vulnerable. So one is you make a better immune response from natural infections. So should you be given that opportunity while you are a child to mount that immune response? The second is that your first vaccination or your first exposure actually shapes your immune response for future responses to infection or vaccination. This is something that is recognized very well in influenza, in dengue, to some extent in HIV and hepatitis C, where if you want the best possible immune response, you need to choose what you're going to infect or vaccinate with very, very carefully. It's called original antigenic sin or immune imprinting. Now, for children, with the vaccines we have in the country, do we know we are offering them the best option? The rest of the world is not using the vaccines that we are using for their children. Are they doing the right thing? Will we do the right thing? It's very hard to tell at the moment. And this, to me, is the time to experiment, to try and figure out what is best. Because at the moment, we have very low circulation of the virus. If, of course, we had a raging pandemic right now, we were in the middle of the third wave, then I would say, okay, let not the perfect be the enemy of the good. Let's vaccinate children now. But that's not the situation today. And I think we can afford to wait, and we can afford to figure out what's best for children.
Because the figures come, October 21st, October figures saying that we've crossed 1 billion, but it's only 30% of the adult population which is totally protected. And, today's paper says the Soviet Union also 30% of their population have been totally protected, and yet they're in the middle of a crisis. So, I agree with you that, I know as a grandmother, I would want my grandchild to be vaccinated if she's going to go to school. But can we flip it the other side that, herd immunity, if we sort of try and get 80% up for the adults, total protection for adults at 85%, then automatically children get protected. Is that right? Is it a way of right looking at things?
Well, given how infectious Delta is, we are closer to 90% of the whole population needing to be exposed or vaccinated for this to work. And even then, it's very important to remember that for things like respiratory viruses, herd immunity is not an on-off switch. It is what changes the pattern of transmission within one community as compared to other communities, right? Now, when it comes to thinking about what's happening in Russia versus what's happening in India, we're in a very different situation because we saw Delta before we got the bulk of the country vaccinated. We know that a combination of infection and vaccination actually gives you the best possible protection. So I think India is in a different situation from many countries that are seeing Delta after they started their vaccination program. And just in terms of the coverage, I'm not worried about the 30% double vaccinated individuals in the country. I think I disagree with Dr. Reddy on some of the things he said about the intervals between the doses. Because quite frankly, I think really long intervals don't matter. What really matters is getting at least one dose into everybody as soon as possible. And there are 25% of adults in this country that have not received even a single dose of vaccine.
Dr. Reddy, which brings me to this whole question of, the figures. When we say 75% of the population is, has been protected even with a single dose, are we looking at urban and tier 1 and tier 2 cities? What about the rural sort of outreach?
Certainly, we ought to really look at the rural outreach as well. But one other point, even people who have received 2 doses of the vaccine, leave aside 1 dose, are not completely protected. Let's remember that. Because if you go by the trials, you have protection rates with Covishield of about 66 to 70%. Of course, Covaxin has spoken about some numbers which still need to be seen fully in terms of publications. Let's say even 80%. And the protection is much higher for severe disease, for hospitalization and death. But if you're talking about any infection whatsoever, the vaccines that we have given will still have at least about 20% who may still be infected despite complete vaccination schedules. So that's one element of it. So we need to continue public health protection measures like masking, etc. It's not just that we are going to depend only on the vaccination numbers, at least till we are fairly sure that the pandemic has been controlled. But certainly we need to increase our outreach to unprotected populations in rural areas and small towns. And that is where I think predominantly it is the public sector that has to deliver, because the private sector was trusted as a possible agent to deliver 25% of the vaccines. But their presence in small towns and villages in the organized private sector is very minimal. Absolutely. So we have to definitely depend upon the public sector. We'll have to find out how best to reach those areas. But given the fact that we will still have a considerable amount of unexposed population to the vaccines and who are potentially exposed to the virus still, we would have to continue these precautions while increasing the vaccination rates. But herd immunity is a bit of a misnomer that really went around a lot in the latter part of 2020 and the first 3 months of 2021, which caused a lot of damage. Firstly, as Dr. Kang said, it is related to a particular population group. If the virus transmission in that group is stopped by a number of people who are immune, either from natural infection or from vaccination, they're protecting the other people who are enclosed in that group, but who do not have that immunity themselves. It's a population attribute, it's not an individual attribute. But if any of the non-immune persons goes to another area, where the immunity levels in that population are only 30 to 40%, and the virus is still in active circulation, this person is at a risk. And secondly, we now recognize, we do not know exactly how long, but we all do recognize that the immunity conferred both by the natural infection and by some of the vaccines is likely to fade in some time. Whether it is going to be 6 months, or 1 year, or 1.5 years, we do not know. I mean, Pfizer says that their immunity levels of antibodies fall from the 5th month onwards after vaccination. Now, they are going for booster doses. Whether that's rational or not is a different issue. But if the immunity is going to last, let's say, 1 year, where are you going to bet on your herd immunity? So there are a number of things that you still need to do in order to protect yourself. You do need vaccination because that's definitely going to affect the transmission rates. If many people do not get seriously ill, then the rates of viral discharge, even from mild infections, is going to be much less. But we cannot bet on herd immunity in the short term in order to overcome this. We have to continue with our public health measures.
No, in fact, now, I mean, coming back to Dr. Kang, are we seeing the pandemic going into an endemic situation? What are the risks involved there?
I think it's already endemic and has been endemic for a while. We have endemicity just means something that is present in the population that will continue to be present in the population. It doesn't mean that we will never see increases in number of cases, that it will always stay at a very low level. But I think we are endemic in the same way that tuberculosis or typhoid or cholera are endemic in India. And yet we see some situations where you see a clustering or an increase or a predilection for certain kinds of populations.
Dr. Reddy, then since we are getting into this endemic phase, are we looking at, and you had mentioned this, the question of efficacy for a few months, maybe to a year. Are we looking at sort of annual sort of vaccinations against, like I remember in our childhood, that, cholera, we were vaccinated against cholera, we inoculated against cholera every year, and then we had smallpox vaccinations every year. Are we looking at a similar sort of trajectory here?
I think it's too early to say the whole population requires that kind of an annual or once in 2 years shot. I think the evidence still needs to be gathered for that. I think the best we can say that people who are vulnerable because of low levels of immunity per se or in response to the viral challenge, natural infection or vaccine-induced viral challenge. They are the people who may require, particularly if they have comorbidities. So the people who are elderly, the people who have comorbidities, people who are immunosuppressed at any age. So those are the kind of people who may require those kind of repeated periodic booster for their immunity. Whether everybody in the general population will require depends, I think, on the state of the pandemic, whether it's faded off completely with only residual pockets, whether new variants have emerged or not, and multiple other factors. But I think evidence is still building up, and I don't think we are at the stage we can say that in 2023, everybody is going to get one more dose of vaccination.
Yeah, because I bring this up because in terms of the costs, I mean, obviously, and Arun can sort of weigh in on this, that if you're going to ramp up our public expenditure on public health, I mean, what is the kind of sort of ramping up and what will be the kind of costs that we will need to sort of incur roughly to do something like that?
The costs are not all that high compared to the GDP. We've been spending very little on public health, and Dr. Reddy would, maybe have the figures for it. We have not exceeded 1.3% of GDP on public health. Our expenditure has been largely through private sector, on health and out-of-pocket expenses. So in a sense, it's all a question of national priority. If you prioritize something, you'll find the resources. If you don't prioritize it, then you keep saying that you don't have the resources. And what we have not done is prioritize education and health enough. In terms of education also, we've seen massive challenges that have come up. Children's education, the psychology of the psychological impact on the children, they are something that we need to also worry about because, online education has been very difficult, both for the teachers and the students. So in a sense, what I feel is that cost should not be worry. What also I would say is that, we should think of it as a public good. Vaccination is a public good. It should be free for all. Whatever be our strategy, as Dr. Reddy said, we can have a strategy of who we vaccinate and who we don't vaccinate immediately, who we vaccinate over a period of time, when we do it. All that can be coming from the health sector. But the resources for that, I think, is not a difficult thing. Because if you think of vaccination also, if you were to give free vaccination to everybody, I think the cost estimated was only about 70,000-80,000 crores of rupees, which of a 200 lakh crore economy is roughly about 0.75% or thereabouts of the cost. So it's not as if we can't afford it. If you think about the black economy, that itself, would give you huge resources if you could tap the black economy. So it's not that the nation doesn't have resources. The nation has the resources. And I think a lesson that the pandemic has shown us is that we are a collectivity. We have to deal with the issue as a collective. It should not be the kind of inequality that's coming up both internationally and nationally in terms of vaccination availability globally, in terms of vaccination availability within the country. And also I would flag the issue of vaccine hesitancy that I think we've been experiencing in India. That also needs to be tackled. And for that, the alienation of the unorganized sector, because in the unorganized sector, that large number of people have sort of been resistant to it, not come forward. That alienation needs to be tackled. For that, I think the government needs to look at the kind of resources that need to be spent on unemployed people, people who don't have employment. A rural employment guarantee scheme is still, a huge demand is there. We've not been able to give work to everybody. RBI data shows that last year we were giving only 50 days of work for the people who demanded work instead of 100 days. And even that 100 days was inadequate. We should have raised it to maybe 200 days. That could be one way of overcoming the alienation among these people because they feel left out. So apart from the public health issue that Dr. Reddy raised, we don't have enough public health primary centers, etc., in the rural areas. I talked to about 25 different people from 25 districts through Zoom meeting in UP in the month of May and June. And they said, people are dying of breathing difficulty. There are no doctors to diagnose. There are no health centers where we can go. So the situation in UP was quite dire. And therefore, those people are people who are alienated. So unless we think of ourselves as a collectivity and deal with the issue in a collective manner, and I think that's the central thing. Once we think about it like that, the resources can be found.
So, Dr. Reddy, in terms of public health, do you think there's a place and a case for better coordination from the center and the states in terms of both allocations for public health and in terms of just the strategies and the operations for public health? Do we need a national coordination body?
We do need national coordination. There's no doubt about it, especially for public health emergencies. There's no question about it. But that doesn't mean that the states should not have the major role in deciding how best to actually implement a particular delivery system. Because ultimately, they have the best knowledge of the ground realities. In fact, what we need is policy coherence and policy development at the central level in consultation with the states. Then at the state capital level, you need detailed planning and allocation of resources. Then at the district level, based on data-driven, decentralized decision-making, you need a lot of flexible implementation at the district level, responding to the evolving ground realities. And it is that connection that has to be maintained. It cannot be purely central diktat. It cannot be purely state autonomy, because particularly it doesn't work overall for public health, and certainly not in the face of a public emergency.
Yeah. So I think I'd like to sort of wind up our discussion on a more philosophical note. So why are, zoonotic infections, animal to human infections, increasing over the past 70 years? Does COVID bring us lessons on how the world must change its designs of development?
I would think so, absolutely. It's very clear that we are seeing far more infectious disease outbreaks which are being spread from animals to humans, either directly or quite often through an intermediate animal host. And that is not because animals have suddenly become malevolent towards human beings. It is because humans have sort of established the conveyor belts for transmission of hitherto confined, microbes, viruses, and also the vectors of various microbes into the human habitat, into captive veterinary populations, which are also being bred in very large numbers. And this is partly because of deforestation, whether it is for rapid urbanization, mining, or even for agricultural expansion or growing grain for animal breeding. So all of these are essentially resulting in an opportunity for hitherto confined microbes to migrate easily into the human population. And then, because we are traveling much more rapidly than we were doing a century ago, we are actually creating a number of super spreader events, both locally and internationally. So we are allowing the microbes to hitchhike their way across the world through us. So both in terms of creating an entry point for the viruses to enter our population and for them to spread far more easily, we are creating, the humans are the agency. We are the agency through which the viruses are actually spreading. I'd like to give you a lovely quote from David Quammen in his book Spillover. It says, quote, "Ecological circumstance provides the opportunity for spillover," that is from one species to another species. Evolution seizes the opportunity, explores the possibilities, and helps to convert spillovers to pandemics. So we open the door for a spillover, but then we allow it to become a pandemic. So we do need to change the way we are creating our own developmental designs for the future.
So I think we need to relook at the development strategy where consumerism has increased enormously. And that's the underlying basis of why the environment is getting affected. And you have extreme, events that are coming up, whether it be floods or it be, other things that are coming up. We also need to look at this development strategy because the nature of trade is going to change. Countries are saying we need to shorten supply chains, otherwise there's a big disturbance if there's a pandemic. So that there may be deglobalization. Automation is increasing dramatically, which means that the unorganized sector will grow and therefore unemployment and the loss of incomes will grow. And therefore the economies will slow down. Where do we provide employment to large number of people who get unemployed? Especially, for instance, recently we've seen in the last 2 years, massive increase in e-commerce, which means the neighborhood stores, the footfalls have declined, and therefore employment there is going to go. Whereas the number of jobs created in e-commerce is very few compared to what the neighborhood stores had. So we're going to see huge unemployment issues. So what kind of work week we'll have, how to give employment to everybody. People have been talking about the universal basic income, but I'm opposed to it because you need to give productive work for dignity. If you give money without work, then you don't get dignity. So I think, we need to create productive work. So there are a lot of challenges in education. There are a lot of challenges, what kind of open book exams to give, how do you get the attention of the children on a small screen for 4 or 5 hours? So the redevelopment, is not the point. Point is development strategy itself, needs to change, and we need to give thought to it now, how we are going to develop in the future, taking care of the environment and other such issues.
No, I think absolutely on that is a really a thoughtful note to close on. And I think COVID has given us this opportunity to rethink this on how we were going to, move forward. So with that, thank you so much, Dr. Kang, Dr. Reddy, Professor Arun Kumar. It has been really a very, very thoughtful session. Thank you so much. Thank you.
Thanks a lot. Thanks to everybody.
Thanks.
Thank you for this eye-opening session and for the fascinating insights on the pandemic and its aftermath.